Hello, everyone. Welcome to another edition at the OrthoNinja Academy. This time we're going to be speaking about calcaneal fractures. And I've got with me Amer, who's been through with us. Both of us have been doing the foot and ankle module for the last couple of weeks now. So this is going to be an interesting one because we stand pretty much as diametrically opposite to each other on this particular topic. Do we fix or we leave it alone? That's the big question we're going to be answering. Amer, I can tell you, is not biased on this, so we'll see what he says when he comes up with his talk. We're going to start off with a case. Okay, so here is a 60-year-old who fell off a ladder, 12 foot high. He's got pain, swelling, and he comes into the emergency room. He's got X-rays, which we are seeing now, and he's a smoker. So, Amer, how do we approach this case?
Okay, so he's fallen from a ladder, 12 feet. It's not inconsequential. So I'd start off with the ATLS approach, and I'm going to assume that he doesn't have any other injuries, but I'd be looking for other injuries because it's an actual loading injury. So things like even tibial plateau fractures, pelvic injuries, the other calcaneus, any spinal injuries.
Absolutely. So 10% of patients with a calcaneal fracture falling from a height, we've got lumbar spine injuries, which we need to look for. So that's the top tip from this history. Okay. So he's a smoker, Amer, and he's 60, which is fairly young. He's fallen off a ladder. We're going to give him some analgesia and get him home.
You know me better than that. So I'm going to investigate him. So
here are the options. Okay, so we've got a poll out for you as we speak. The question is, should he have a CT scan? So the evidence seems to be quite divided on this. It says calcaneal fractures do no better with surgery, so let's not fix it. Why bother? And he's a smoker, so the risks of infection. Your other option is a CT scan may help classify and facilitate open or keyhole reduction. Okay. Primary arthrodesis will give him the best results, so there's no CT required for that. I'm not quite sure about that last one, but let's see what the audience seems to answer. So, Amer, I'd like you to go ahead early on in this talk and pin your colors to the mast. Are you a fixer or not a fixer?
So I'm a fixer. So there is a significant amount of literature, but like we discussed last week, the literature is evolving. We don't actually have any definite rights and wrongs. I think
we've had 30 years, 40 years worth of literature. How much more does it have to evolve now?
Technology, things are advancing, and I think especially over the last 10 years, we're getting a much better idea of the way that we should be approaching these injuries. There are lots of means of approaches to surgery that have been tried before. A lot of them have caused a lot of complications, and we're shying away from them now. But that doesn't mean that there aren't more options, and technology is helping us with that. Okay. So let's have a look at our responses. So there's one person who agrees with you that he's a smoker, he's 60, and the risks from surgery are high, so shouldn't have a CT scan. There are quite a few who want to have him scanned, and I must say that's what I would do. I want to classify the fracture, whether I was going to operate or not. I want to know what kind of fracture it was. And primary arthrodesis, I think it's a bit early to be saying that he needs to have an arthrodesis, so I wouldn't choose that option.
We're both in agreement about getting a CT scan because we want to classify that fracture, because that teases out which way we want to head. Now, I think where we will possibly diverge is the method of proceeding thereafter. So after a CT, you're going to possibly fix this fracture. That's going to be your default position unless there is something which contraindicates that, correct?
Yes. I mean, what we can see from that X-ray is that...
Yeah, so talk us through that X-ray.
Okay, so I can see that the articular surface has been depressed. I can see the articular surface on the talus, and the articular surface on the calcaneus looks like it's about 60 degrees away from pointing in the wrong direction. So it's been punched down by the talus. And what that means is that I'd be concerned that he doesn't have a congruent articular surface, and that's going to give him a high risk of developing degenerative change. And I think, we know that people don't do that well from calcaneal fractures. It's one of those injuries where people may have long-term pain and they quite often never go back to the same job that they had before. This guy was a Palladder. I don't know what he does for a living. Maybe he's a window cleaner or possibly. So I'd want to try and get him back to his previous level of function. So I'd be considering that. And looking at the type of injury with that joint depression, I'd want to know how much of the joint is affected and by what degree, so that we can plan surgery if that's appropriate.
Okay. So for some of our junior surgeons in the audience, what Amer is talking about on that X-ray is that double shadow. The posterior facet of the calcaneus is pretty much tilted this way by 60 degrees, as he's put it. Okay, so let's move on. So you got your CT there, and do you want to talk us through those images?
Okay, so in the left-hand image, we can see that there's been some depression of that joint fragment. It actually doesn't look as bad on this image compared to the plain X-ray, but what we can see is that there's a step in the joint surface at the just above the angle of Gissane. And looking at the axial view, it looks like there's indeed a step in the articular surface, and the tuberosity fragment is more posterior, and there's also a fracture of the sustentacular fragment as well. But the joint surface clearly isn't going to be congruent because of that step on the axial. And then on the coronal view, we can see again that there's some shortening of the calcaneus, and the lateral fragment is depressed and angulated, and also the lateral wall appears to have been blown out a bit, so there's a risk of developing peroneal tendon impingement because of that shortening and and widening of the heel.
Okay, so just talk us through your thought process as to why you want to fix most of these by default. Is it, you must have some criteria for a calcaneal fracture, because I do tend to fix some of these, but I have a very narrow criteria for those, because I prefer to primarily fuse them delayed. Now you're going to argue against that and hopefully convince us otherwise. But what is your, before we get stuck into the gist of the talk itself, what is your criteria when you see an X-ray and when you see a CT scan? What is going to make you decide that this needs fixation? Or is it all comers get fixed?
Well, no, I'm quite selective. So I think that if someone has an intra-articular fracture, and especially if there's a two-part or a three-part fracture, I think those are most amenable to surgery. If it's completely undisplaced on the CT scan, then I'm not going to offer the patient surgery. If it's really smashed to smithereens, and I don't think that surgery is going to give them any benefit, as in I want them to be able to have early range of movement after any operation. And if they've got a joint which is so comminuted that it's not going to be feasible for them to be able to move that joint, or it's going to be painful, too painful to move, then I'd shy away from trying to operate on them, unless there's some additional benefit, like trying to get the bony components in a position that might make it easier for me to do a fusion later on. But
go on, sorry.
But looking at this, it looks like it's the articular surface of the posterior facet is split in two, and I think that that's something that's amenable to a simple intervention that might allow correction.
What about things like workers' compensation and smoking? Would that make you think, hang on, you know what, I'm going to leave this patient alone, let them gum up, and then give them one surgery, predictable surgery such as a fusion? Or would you still, in those cases, go in and try to rectify the anatomy?
So workers' compensation is associated with a poorer result, but what's probably more associated with a poorer result is a non-congruent joint. And if he's a smoker, that would certainly put me off doing an extended lateral approach, because I'd be concerned that he would have soft tissue issues. But I am a keyhole surgery person, so even in a smoker, I'd be quite happy to use keyhole surgery, because I think I can manipulate that back to a decent position.
So if we want to give one top take-home message today, right at the outset, to our colleagues and our audience, extensile lateral approach is a no-no. Would you agree or disagree?
I think certainly for this patient, it's a no-no.
Okay.
There are some people who will swear by that approach and say that in their hands it works. I've used that approach previously, but it's not my choice, not my favoured choice for calcaneal fracture surgery now.
And the literature doesn't seem to back up the use of an extensile lateral approach, does it? With regards
I think
to complications and morbidity associated with it?
It's have a lot of complications, but again, there's no black and white in the literature. It's not absolutely clear that it's the approach that is the problem. It may be our surgical lack of preparation. There may be other factors at play, but in general, I think everybody's shying away from the extended lateral approach now.
Okay, great. Let's see where we are at. Yeah. So here's a man after my own heart. The CT has just costed money. We knew there was a depression there. Okay, you're just getting it in a 3D format now. Your options are the extended lateral approach is still possible. Yes, there are risks, but we take those risks. Keyhole surgery is possible and the risks are minimal. This is unfixable in a smoker, so fusion is the best option in a few months.
So
here is a poll going out to our audience. Let's see where they are at. So I take it you've already said you're going to be fixing this, correct?
Yes. So going through those options, I've decided already it's displaced. He's likely to get poor result from conservative treatment. The extended lateral approach, I'd be very reticent about doing it, especially in somebody who's 60 and a smoker. I don't think the risks are acceptable. Keyhole surgery is my choice of treatment for most people, and unfixable in a smoker. Fusion is an option. I think that's not an unreasonable way to approach it in somebody who's 60 and a smoker, and you've got to give the patient all the different options and give them the choice, basically.
Okay, so I've got a disclaimer here. Amer taught me the percutaneous approach. He's a great. He's got lots of skills when it comes to percutaneous fixation of these fractures. But I'm going to push you here, Amer, okay? Because I'm going to play devil's advocate and push you here. He's 60. He's a smoker, okay? Are you in agreement that the die was cast at the time of the injury, that cartilage has been damaged to a large extent? So he is going to have stiffness and possibly traumatic arthritis no matter what we do. Are we in agreement there?
I think that stiffness is contributed to not just by the injury, but also by our treatment and rehabilitation. So one of the main aims of surgery, if you look at the AO principles, are that you anatomically reduce, you get rigid fixation, and you aim for early mobilization. And so I still believe in that, and I believe that if we can fix them rigidly and we can start early passive mobilization, then we can actually avoid stiffness. It may be that if the damage to the joint surface is so severe, they may develop degenerative change, but we know from there's lots of evidence from different joints that the more anatomical the reduction is, the less likely it is that someone is going to develop post-traumatic arthritis.
So you're swinging the audience there. But there is enough evidence to suggest that at the time of injury, damage occurs to the chondrocytes and the cartilage, which predisposes to traumatic arthritis, no matter what we try to do, correct?
And
so
you can develop chondrolysis, as a result of that.
So here's my question to you. Why put this gentleman through 2 operations? Because he is going to need a fusion at some point in the future, more than likely. We can't say for sure, but more than likely. So why not just let him gum up, go in maybe 12 weeks down the line and fix him, or fuse him, sorry. Because you're giving him one procedure, it's a predictable operation, and as you rightly put it, I appreciate when the joint is not completely trashed and the anatomy is not distorted, it's probably worth just fusing. In the joints where the anatomy is completely distorted and trashed, then yes, percutaneous fixation comes into its own to try to just get it back into some semblance of normalcy, so it makes your fusion easier at a later stage. So why not just go ahead and give him a fusion at a later stage now when that joint's not too bad?
Because the evidence in the literature says otherwise, that actually the rate of subtalar fusion that's required for patients, especially who have keyhole reduction, is incredibly low. And even in some of the big papers that we're going to talk about, looking at the rate of fusion for conservatively treated versus surgically treated patients, the rate of subtalar arthrodesis is lower in those that are treated initially with surgery. So there is some advantage. Okay,
so I'm sure you're going to try to convince us through the course of your talk on this, and I look forward to that. So here is it. He would like to know his options to maintain movement. So you tell him open surgery with extended lateral approach for an anatomic reduction, arthroscopic assisted reduction, or indirect reduction with Essex-Lopresti maneuvers. Okay. So let's see. This is your post-op following MIS surgery, right? This is one of your cases.
Yeah.
You want to talk us through this approach? I'm sure you will talk
okay, so
us through this, but just briefly.
we're gonna go through the approach, but what I'm hoping I'll be able to do is to convince you that this kind of approach is something that is reproducible and is reliable. And especially if you use an arthroscope, you can see the articular surface, and it's possible to reduce things to a level that even with open surgery you might not be able to achieve. So if you look at,
that's beautifully reduced. I mean, we're matching up the pre and post-op images one next to the other, and you've got a fantastic anatomic reduction there.
Yeah, but this is not a flash in the pan. This is something that is reproducible. So it's something that we, if with the correct amount of consideration and preparation, you can achieve this for most patients.
Yeah. So hopefully we're going to learn that technique from you through the course of this talk. So I'm going to hand over to you for the talk on calcaneal fractures. It's a shame that patient landed up in my clinic 6 months later for a fusion. I'm just joking.
Yeah. Right. So
over to you, Amer.
Thanks very much. So it's always good to have a chat with Raheel, because there isn't only one way of doing things, and it's important that you appreciate that there are different opinions, and in the literature there are different ideas about how you can do things, and especially in orthopedics, the quality of the literature isn't that great, and you need to be able to critique the literature so that you can discern what you feel is right and what's going to work for your patients. So we're going to talk about calcaneal fractures, and the subject matter that I'm going to talk through. I'm going to start off with the epidemiology. We're going to talk about the anatomy of the calcaneus, because that's obviously very important in the way that it breaks and what you're trying to put together. We're going to go through classifications. Now, classifications in orthopedics may not be incredibly helpful for determining the management, but it does mean that we can compare like with like if we are looking at papers, we want to know what kind of comminution there is in each particular group of patients, and I think classifications are very good for that. They can also help you to decide what kind of treatment may be appropriate for the patient. We'll do a little bit about clinical assessment, but usually this is something that's very obvious and apparent. We'll go through what imaging is required for planning the patient's treatment, and then we'll go through the surgical techniques. And when we go through the surgical techniques, I want to try to present as broad a range of techniques as possible. So I'm going to talk to you about techniques that I may have given up already, but which are important for you to know about. And then we're going to talk about outcomes. And again, although I have my own preferences for how I would treat calcaneal fractures, I'm going to try to talk about outcomes with different techniques and go through the literature, and then try and sum up about whether we should fix, and if we are going to fix, how are we going to fix it, and when are we going to fix it. I'm going to try and give you an algorithm which might aid you in your decision making as well. So first of all, fractures affecting the hind foot, it's the most common. So it's about 60 to 70% of tarsal fractures, and it's 2% of all fractures that present to you. So that's 11.5 per 100,000 of the population, and it seems to be men that are affected more than women, and that's often associated with employment, and the vast majority of them involve falling from a height, and that may be as low as a few feet, but quite often it's our patients will have fallen from more than 12 feet, and that's something that we need to take very seriously, because that's now a high energy trauma. So it's important to know about the anatomy of the calcaneus, and we'll start off in the bottom left-hand corner. So we've got the tuberosity of the calcaneus at the back, and we've got the sustentaculum tali. And the sustentaculum is basically where the talus is sitting on top, on the medial side. If we then go to the top left picture, you can see the articular facets on the calcaneus, and the one that we're mainly interested in is the posterior facet, which is the big one that articulates with the posterior facet of the talus. But also there's a middle and an anterior facet as well, and there's a large area which is non-articular. And then if we go down to the bottom right, you can, on the other side of the calcaneus, on the lateral side, there's the anterior process of the calcaneus and the sinus tarsi sitting between the calcaneus and the talus anteriorly, and you've got the tuberosity of the calcaneus posteriorly. Now, I think what's really important to understand is that this is not just a fracture. It's not just affecting one system. So yes, there's a bony injury, the calcaneus is broken, but the calcaneus is mostly trabecular bone, it's cancellous, and that is going to heal up. What we're more concerned about is the articular injury, so the articular injury to the posterior facet and to the calcaneal cuboid joint, and sometimes even the sustentaculum as well. And then we also need to think about the soft tissue injury. So the heel fat pad is often pulverized. If enough force has gone through this body to break the heel bone, then just think about what's happened to the more friable fat pad underneath the heel, which acts as a shock absorber, and that's going to be pulverized. And quite often patients complain of pain underneath their heel in the fat pad for a year or so after their injury. So that's a significant component as well. Now, when you're looking at x-rays, you need to know about Bowler's angle and Gissane's angle. So Bowler's angle is a line it's an angle subtended by the line joining the most superior part of the calcaneus at its posterior aspect and the top of the posterior facet. And then the second line for Buller's angle is between the top of the posterior facet and the top of the anterior facet. That's normally between 20 and 40 degrees. And there's Gazane's angle, which is formed by the posterior facet coming down to meet a line joining the bottom of the posterior facet with the anterior process of the calcaneus, and that should be between 130 and 145 degrees. And quite often on X-ray you will see an area which looks a little bit empty, and that's called a neutral triangle because of the paucity of trabecular. So, as I've said before, this is an axial loading injury, but the talus is sitting on the sustentaculum. So if you look at the right-hand picture, you'll see that when you land, essentially there's a shearing force, and that shearing force, as the calcaneus is being pushed up by the ground reaction, and the weight of the body is pushing down, and there's a shearing force across the calcaneus, and that tends to cause a primary fracture line. That primary fracture line will be sort of anterior and lateral, and posterior and medial, and it will go across the posterior facet of the subtalar joint. That's our primary fracture line. But then there will also be secondary fracture lines, and these will come off from the primary fracture line. And if the secondary fracture line exits from the superior surface of the calcaneus, then we end up with a joint depression type fracture. And if the secondary fracture line exits from the posterior surface of the calcaneus, then we end up with a tongue type fracture because the superior fragment is all one piece. And that's reflected in one of the classifications. So Essex-Lopresti can either be you can either divide them into extra-articular fractures or intra-articular fractures. So the extra-articular fractures, which are the minority, are things like the anterior process of the calcaneus, sustentacular fractures, perineal tubercle fractures, tuberosity fractures like that picture on the left, which doesn't go into the joint at all, and TA avulsion fractures. Now, TA avulsion fractures can be a problem because the avulsed fragment does cause a lot of pressure on the skin, and if it's left there, it can cause necrosis of the skin, which is a nightmare, and you need the plastic surgeons to cover that up for you. So that's actually something that needs to be dealt with urgently. And then the second type of Essex-Lopresti fracture is the intra-articular group, and the intra-articular group can be either centrally depressed if the secondary fracture line comes out from the top, or it can be a tongue type when the fracture exits from the back. Now, the other classification that you'll have heard of is Sanders classification, and this is based on CT, and you need to look at semi-coronal reconstructions. Now, quite often we don't get semi-coronal reconstructions, and we just go off on the axial because that's the series that we get from the CT scan. And the classification really depends on the number of fragments in that important posterior facet, and then whereabouts in that posterior facet the fracture lines are. So you can have a one-part fracture, which sounds a bit illogical, but essentially it means that it's completely undisplaced. And those are the types of fractures that you could treat conservatively. Then you can have 2 or 3-part fractures depending on where the fracture lines are. And this is type 4, where essentially you've got a mushed up joint surface, which is not reconstructable. And here's a demonstration. So we've got the semicoronal CT there. We can see the posterior facet. And if you look at the images on the right, you can see we're looking at essentially the same kind of section. The C-type injury goes through just next to the sustentaculum tali, and the A-type goes more laterally, and the B is somewhere in between. So we're looking at that axial, and we're essentially looking for those lines to try to classify with Sanders. If you're going to assess the patient, you're always going to start with ATLS because it's a high energy injury to break the calcaneus, and you need to be aware that other injuries may have occurred and exclude these. Quite typically, the patient's fallen from a height. Most commonly it's a ladder. We sometimes refer to these as the lover's fracture, where someone's jumped off a balcony, or a burglar's fracture, where someone's jumped off a balcony after they've been burgling someone's house. We need to know if the patient's smoking, and we need to know what kind of work that they do. And when you're examining the patient, you need to be wary about compartment syndrome and examine them for tenderness, bruising, swelling, and fracture blisters as well. If you're going to image the patient, normally we get a lateral of the ankle, and then we try to get an axial. And in order to get an axial, you need to have the beam tilted about 30 or 40 degrees. And this can give you a decent image, and it might be able to show you the subtalar joint, but it's often quite painful for the patient to have an axial that shows the posterior facet. So it's not always an important investigation, and I pretty much always ask for a CT scan. And it's going to allow us to classify it, and it's going to help us decide, is this an intra-articular fracture, because those are the ones that really need to be fixed if there's displacement of the joint. We can also identify sort of key structures that might be important for our surgery. So, as I said before, this isn't a black and white issue, and there's a role for all different types of management, and we need to be able to make a decision based on the evidence. So, you can treat some things conservatively. So, if it's a stress fracture, if it's undisplaced, some people would argue that if a patient smokes, then they shouldn't have surgery. Some people would argue that if it's comminuted, they shouldn't have surgery, and some people would argue that all calcaneal fractures shouldn't have surgery, but that's something that's still very controversial. So let's have a look at the extended lateral approach. This approach basically is going to develop a flap on the lateral calcaneal artery, and we shouldn't be operating on a patient with this approach soon after their injury, because there's a lot of soft tissue damage, and you want to wait for the swelling to settle down. So the people who do this generally wait for 10 to 14 days, and you can see in that right hand image what I'm doing is I'm just giving the foot a little bit of a twist, and there's some wrinkling of the skin, and the wrinkling of the skin essentially tells me that the swelling is on its way down. I'm going to put the patient in a lateral position, and we want to be able to get three different types of x-ray: a lateral view, a Broden view, which is externally rotated at 45 degrees, and an axial view as well. Using this approach, we are able to draw up this full thickness flap, and the idea is that you get down to bone and you stay on bone. So the lateral calcaneal artery is somewhere in that flap, and you're going to try to avoid injuring that, because that's going to keep the flap alive. And the sural nerve is also in that flap, and we need to avoid that. But necessarily, we're going to injure the calcaneofibular ligament. Once that approach has been used, it's possible
to hear, Amer.
Yes, of course.
How often have you used this extensile approach? Because it's right through my training. I've probably seen this thrice, because more and more people have decided to either fix percutaneously or leave them alone. So how often have you seen this? Is this because with new surgeons coming through training now, a lot less of this approach is being done, particularly in the West. So,
and absolutely, I don't use this approach anymore. I did use this approach all the way through my training, and for the first couple of years as a consultant. And I'm going to show you a case a little bit later on, which is one of my disasters. And that is going to be the explanation as to why I stopped using this approach. But there are still people who swear by this approach. And so it is something that you will come across. Perhaps less so in the West, but it's still practiced quite widely. The way that once the flap's been elevated, what you can do is use K-wires to prevent the flap from dropping back into your operative field. So the K-wires go into the talus, and then you bend them 90 degrees so that they're holding the flap, and you can see the subtalar joint, but the K-wires are not going to get in your way. And these images basically show three different views. So we've got an axial on the right-hand side. We've got a Broden view, which is looking straight down the posterior facet by putting the foot into 45 degrees of external rotation, and a normal lateral view. And you can see the plate that's been used, and that plate you can put directly onto bone because you've essentially flayed the entire calcaneus. You've exposed the whole bone. And that's one of the reasons that I'm not very happy with the approach as well. So actually the reduction is straightforward. You can see everything. It's quite reliable in being able to reduce those fragments anatomically. And that's what you'd expect with such a large approach because you can see everything. So this is one of my patients, and I think this is from about 10 years ago, Raheel. So this is the reason that I stopped doing the extended lateral approach. And I'm not the only person who's had this problem. The patient waited 10 days from the time of his injury. His wrinkling had appeared, so I thought that I was safe. But clearly the flap is dying, the skin is dying, there's a lot of necrosis there, and this is something that's going to need a free flap in order to cover this up now. So it's a disaster for the patient because they're now going to have even more surgery. And it's a disaster for me because I don't want to have to put my patients through this, because I know that if they have a free flap, they're going to be disabled because of the amount of soft tissue that's going to go onto that. They're going to find it difficult to get into shoes for the next year. So this is something that we need to try to avoid. And as I said, there are people who still use this approach, and they have arguments as to why they do that. So if you look in the literature, about 25% of patients have wound problems of one type or another. You can see that on these two images that on the right, they're from someone else's paper, and you can see that there's some necrosis in the top image, and there's exposed metal on the bottom image, and it's relying on a branch of the lateral calcaneal artery to keep that flap alive. We don't know whether that flap may have been injured as part of the soft tissue injury. Now, this is a paper which actually throws some doubt on those of us who are not keen on that particular approach. They've looked at 90 fractures, and what they've done is they've actually identified 5 patients who didn't have a Doppler signal from their lateral calcaneal artery, and the other 85, they did have a signal. And what they found was that the ones who didn't have a signal all had wound problems, but the ones who did have a signal, only 1 out of the 85, so that's 1%, had soft tissue wound problems. So it may be predictable whether people are going to have issues, but I'm still very doubtful despite this paper, because I've looked at lots of other studies, and each one of them from quite reputable authors have said that they've had about a 1 in 4 rate of wound problems. So
and the question,
this may
you've
yes.
got to ask the question, if you can get a fairly reproducible congruent joint without flaying open that foot, why do this?
Absolutely, absolutely. I can see the merit of their paper, but as I'm in the majority of surgeons who have found that there are soft tissue issues with a lot of these patients who've had an extended lateral approach, I won't use this approach again. And even if you can get an anatomical reduction, as you say, there might be some chondrolysis because of the injury itself. So there's still a risk of post-traumatic arthritis. We know that it's related to how well you reduce the joint surface fragments. The lateral wall blowout can lead to impingement of the perineal tendons, and that might be another reason to go back in and operate on the patients. So what I'm trying to say in this talk is that the extended lateral approach does give you fantastic vision and you can reduce everything anatomically. But are you helping the patient if you've given them a second massive soft tissue injury? And that soft tissue injury is associated with pain and stiffness and a lot of swelling. So it's preventing the early mobilization, which I think is important for managing these particular injuries. So let's talk about Buckley's paper, because this is, if you're going into any exam, this is one that you need to know about. A lot of people quote it, and it's a paper from Canada from 4 different centres, and they took 424 patients and they randomised them to conservative or operative treatment using that the extended lateral approach, and they looked at lots of different variables to assess if there had been any difference between the two. And what they decided was that actually there wasn't any difference in the outcomes between the operative and the non-operative group. But obviously there was a difference in terms of the number of complications because of the surgery. So this paper is cited by many people as being a justification for not operating on calcaneal fractures. However, this is why critiquing papers is important, because there are lots of buts. If you look into the paper in a bit more detail, you find that there are some groups who did benefit from surgery. So younger patients seem to do better than the non-operative group. For women and patients who are not on a workers' compensation scheme. Another criticism of this paper is that they asked each centre to recruit 20, but actually one centre and one surgeon operated on the vast majority of the patients in this study. And their power calculation may have been flawed. So they actually needed 3 times as many patients in order to be able to demonstrate a difference, if a difference existed between these two groups. There were quite a few patients who were not recruited or lost to follow-up who had calcaneal fractures. And what's interesting is that there was a difference in the requirement for subtalar fusion. So patients who had surgical treatment of their calcaneal fracture, there was a statistically significant difference in that they needed subtalar fusion less than the patients who'd been treated conservatively. Second paper that you need to be able to quote in an exam is Griffin. So Griffin et al. Produced their paper. It was called the UK HEAL trial. Again, a multi-centre trial. It was published in 2014, and they only had 151 patients in the trial. And again, they decided that there was no difference in the outcome between conservative and operative treatments. And obviously, if you have an operation, you're going to have some complications from that. So they said there were more complications from the operative group. But again, if you look at that a little bit more closely, there are some questions that have to be asked. So the two groups, their operative and non-operative group, weren't really comparable because their operative group had a much higher number of smokers. They only followed the patients up for a few years, so they couldn't actually tell us what the rate of subtalar fusion was like. And actually, subtalar fusion if you have early surgery, that means that if you do have to have a subtalar fusion, it's a little bit easier because all the bone fragments are in the right position. They were satisfied with a less than perfect reduction, which is something that perhaps most of us wouldn't be for a calcaneal fracture. And the other very odd thing about this study is that there were 2006 patients who were enrolled, of which they felt only 502 met their inclusion criteria, and then only 151 were finally included in their study. And a lot of their exclusion criteria were a little bit bizarre. So they said that if the patient had fibular impingement, then they would take them out of the study and they would automatically get operations. If the fracture was very comminuted or grossly displaced, then they wouldn't randomize the patient. They'd say, well, they clearly needed to have surgery because it was grossly displaced. So it actually narrows down the patients who were included in this study to patients who were essentially in the equivocal group who may or may not have may not need to have surgery. So it's by taking out the patients who are definitely going to be treated conservative and definitely needed to have surgery, it actually means that it's difficult to know whether their power calculation was correct.
But wouldn't you argue, Amer, that that's a perfectly reasonable indication for fixing? Because although I don't fix, I have a narrow indication, as I said. One of my indications to fix a calcaneal fracture would be fibular impingement due to a lateral wall blowout. So,
but in terms of a trial, if you want to compare patients who have and identify if surgery is beneficial, then actually, if you've got fibular impingement or gross displacement, then surgery would benefit that patient quite markedly. So why remove them from the trial? If you're going to randomize all calcaneal fractures to operative and non-operative, why remove an important group of patients from the trial? So that's what I'm querying. There are lots of reasons that we could question this trial, and there are arguments both ways. I'm sure there are answers to some of the questions that I've raised.
And we know this trial changed practice in England, don't we? Significantly.
Absolutely. So many people change their practice on the basis of this, so that less people are practicing calcaneal fracture surgery now than were 10 years ago. But those are only 2 papers, and there are a lot of other papers. So there are at least 8 good randomized controlled trials. And what's useful is to try to pool all the patients from these different trials. So what we can see from 2 similar papers which reviewed all of the trials and pooled the patients can be summarized with these forest plots. So if you look at the top right forest plot, this is looking at whether it's beneficial for patients to have surgery and their likelihood of returning to their pre-injury work. And the forest plot shows that quite obviously patients who have had surgery are more likely to return to work doing the job that they did prior to their injury. If you look at the middle forest plot on the right, you can see this is looking at residual pain. And the forest plot demonstrates that those patients who've had surgery are in a lot less pain than those patients who were treated conservatively. And if you look at the bottom forest plot, looking at patients' comfort in wearing shoes, what we can see is that the forest plot quite markedly demonstrates that those patients who are treated operatively are more comfortable wearing shoes compared to those patients who were treated conservatively. Now, these are all nuances of the trials that I think are quite important. But if you look at the forest plot on the left-hand side, this is looking at the American Orthopaedic Foot and Ankle Society score, the AOFAS score, which is something that's quite used quite widely to judge the outcomes from studies. And interestingly, the AOFAS score overall seems to favour non-operative treatment, but those three the three forest plots on the right would seem to suggest that actually there is some benefit for the patient, even if you consider that on the scoring system, it's possibly not so beneficial for the patient. But there's some real issues like going back to work and being in pain that are important for patients. And my view of these RCTs is that we're comparing two different options, both of which may have a poor result. So conservative treatment, we know overall is going to cause a poor result. And the extended lateral approach, because of the amount of soft tissue problems associated with it, is also likely to cause a poor result. So we're comparing hanging against the electric chair. We're comparing two bad options. So what we really need is to be able to compare conservative treatment against other surgical options. And that's what we're going to talk about later. So the other options are minimally invasive surgery, and there are different techniques. So there's the Essex-Lopresti technique, which is an entirely percutaneous technique. There's a mini open approach, which goes in through the sinus tarsi rather than the extended lateral approach. And there's an arthroscopic assisted reduction, which I'm going to show you a little bit later. So this is one of my patients. We're performing an Essex-Lopresti reduction. We need three different views. So we need the patient's in a lateral position. We have to have the X-ray source under the table and the intensifier, the screen on top, so that we can get a decent view. And we can see a true lateral of the foot. And we can also externally rotate the foot 45 degrees to get the Broden view. And then if you externally rotate the knee and you dorsiflex the foot and you tilt the image intensifier as I've shown in that image, it's possible to then get a good axial of the calcaneus and see the subtalar joint. So you can see the articular surface of that posterior facet. Once we've identified the anatomy, you can see in this image intensifier film that there's a fragment which has been depressed. I'm going to use some Steinman pins to go underneath that fragment, and the pins are introduced either side of the Achilles tendon, and then they're pushed by hand, not by power, underneath that fragment. And in order to identify which direction to go, you need to have a look at the CT. You get under the anterior aspect of that fragment, and then we're going to start levering on that fragment. Now, unfortunately, that image isn't very good, but you can see the two pins in the X-ray image on top. And in the image below, you can see the two pins which are converging on the fragment that I'm interested in. And I'm going to pull down on those pins, and at the same time I'm going to pull the foot down. And looking at the image intensifier, you'll be able to see the reduction. It's a risky procedure because you only really get one or two shots, and if you don't get a good purchase in the bone, then what can happen is that you can fragment the surface even more. But when we watch the video, you're going to see that we have to bend the pins quite markedly in order to
use the Essex-Lopresti technique, you need the patient in a lateral position. A pin needs to be put in next to the Achilles tendon, and these two pins will converge underneath the segment to be elevated. It needs quite a lot of force. As you can see, these are 5mm pins and they're bending quite a lot. If you look underneath the two pins, you'll be able to see a white space, and this is where the bone originally started from. This space will fill in automatically, and there's no need to bone graft. As we're lifting up, we can see how the joint is now congruent again and the angle of Gissane has been restored.
Okay, so I hope that video gave you a good demonstration of exactly how the surgery is performed. So we're just levering up almost like a seesaw. So we pull down at the back.
You are plantarflexing that foot to relax the Achilles tendon, correct? To get that maneuver easy.
Yes, that's right. Yes. So the knee's normally a bit bent as well. Right. So for fixation, once you've managed to reduce those fragments, it's important to hold them in that position. And the way that we're going to do that is by putting in some percutaneous screws. The Steinman pins are going to be keeping the reduction, and then going to transfix the articular surface by using some K-wires through the heel that go through the calcaneus and into the talus, and those will then hold everything in the right position. And then I can replace the Steinman pins with some fully threaded screws like this, and they're acting as raft screws, so they're preventing that fragment from then falling back down again. At the same time, we need to keep the articular surface as compressed together as possible, so I put some screws in from the lateral side, aiming towards the sustentaculum, so that I can compress the articular surface, and I should be able to avoid going into the articular surface when I do that. This is the Sinus Tarsi approach. So it's starting, the incision starts at the tip of the fibula, and it goes down to the fourth metatarsal base. So that's a conventional utility approach that we use for subtalar fusion. And through this approach, you can see the lateral fragment, and you can put an elevator in and lift up the lateral fragment that's been depressed in the angle of Gissane. And you can also put an instrument in to try to decrease the overlap between the sustentaculum and the main part of the calcaneus. And this has got a little plate which is designed for the Sinus Tarsi approach.
We just share.
And this is another
the audience handout on external versus minimal invasive approach paper, just so the audience is aware. Sorry to interrupt, please.
Okay. Okay, and this is yet another approach. So here we've got a patient who's got a comminuted articular surface, and what the four images on the top right are mine, and what I've done is I've introduced an arthroscope from posterior, so the patient's in a prone position. I've put that arthroscope down the back of the posterior facet, and that's allowed me to see the articular surface, and it's possible to see the three pieces of the articular surface. Now, what I've done then is to put in a threaded guide wire, and you can see that in the group of four pictures on the bottom left, bottom right, you can see something shiny, and that's actually a 3.2mm guide wire, and I can then lift up the fragment under direct vision, and that allows me to then reduce that pretty much anatomically. And then in the same way that with the Essex-Lopresti technique, I put in some percutaneous screws, I've done exactly the same for that patient. And you can see the final result in the bottom left-hand corner. So you can see that the articular surface, the middle third, which was depressed, has now been elevated back up again. So what we need to decide really is percutaneous surgery any better than open surgery? Is primary fusion an option for severely damaged joints? And of all those different techniques, which is better? percutaneous surgery or sinus tarsi, mini open incisions, or the arthroscopic assisted. And that's what we need to look into the literature for. So we can't actually say that percutaneous surgery is any better than any other type of approach. But there are more and more studies coming out which are showing the advantages of this approach. So there's two papers on the right. The bottom one is from that man Buckley, who was responsible for the Canadian study. And I think it's really interesting. We were talking before about the rates of subtalar arthrodesis, Raheel. Chen's paper in 2010 using a keyhole technique, they found that 132 of their 210 patients returned to their original work at only 5 months post-op, which I think is remarkable. They had about 10% who had radiological osteoarthritis, but only 4 of their 156 patients were actually symptomatic from their arthritis, and not a single patient had actually undergone a subtalar arthrodesis. And the papers from China are actually very useful because they are massive numbers. They're numbers that we just would not be able to achieve in the West without having large multi-center trials. But in China, there seem to be trials which are recruiting enormous numbers of patients, which is very useful for being able to work out the science of whether it's an advantageous approach. So is primary fusion an option? Well, there are, again, papers which demonstrate that, in fact, if you fuse someone primarily, their outcome isn't really that much better than if they have open reduction internal fixation. I suppose the advantage of fusing someone primarily is that they only have 1 operation instead of 2, but the rates of arthrodesis are actually quite small. So it may be possible that, immediate fusion is jumping the gun a little bit. And there are no downsides to fusion compared to open reduction, but it makes you wonder about if you do open and reduce, are you improving the position of the bone so that if you do have to do a fusion later on, it's going to be easier. So there are lots of questions that still remain unanswered. So this is how I make my decisions. It's just one way of doing it. I'm not saying this is the only way of doing it. So if I've got a calcaneal fracture, if it's extra-articular, I'd be concerned. If it's a TA avulsion, that needs to be urgently reduced and fixed. So I put a big clamp on that, bring the fragment down and put some percutaneous screws through it. If it's extra-articular and it's not involving the Achilles tendon, then I'm going to treat that conservatively. If it's an intra-articular fracture, I think it really depends on your skill set. If you've got a Sanders 1, so an underspaced fracture, then you can treat that conservatively. If you've got a Sanders 4, so it's one where the joint surface has been pulverized, if they're a smoker, then I'd be very reluctant to do anything to them, and I'd treat them conservatively and I'd offer them a late fusion, but I'd try to get them to stop smoking first. If they're not a smoker and they have a pulverized joint, then I think offering them a primary fusion is not unreasonable. The area where there's most controversy still is really in the Sanders 2 and 3. So if they're a tongue type, I will always use the Essex-Lopresti technique because I've seen in the literature a lot of people using the mini open technique and plating for the tongue type. I really don't feel that's necessary because we can get such reliable, good results with tongue type using the Essex-Lopresti technique. For the central depression fragments, again, I think that surgical intervention is helpful, but whether Essex-Lopresti or Sinus Tarsi approach or an arthroscopic assisted approach is the best means of giving the patient a reduced joint, I don't know, and there's no clear evidence in the literature to say that one way is any better than the other. But I'm hoping that's something that's going to become more clear with time as more studies get published. So in summary, we've gone through the epidemiology, we've talked about the anatomy of the calcaneus, we've talked about the classifications and what use they are, we've talked about the different surgical techniques, and we've been through the literature to try to decide, should we be fixing fractures? If we are going to fix them, how are we going to fix them? When we're going to fix them? And I think it's just important to remember it's a multi-system injury, so it's not just the bone will heal up. But as Raheel pointed out at the beginning, it's what happens to the joint. If you have chondrolysis, then that means that they're going to end up having an arthrodesis. And also think about the soft tissues in the heel fat pad underneath, because those have been pulverized and they're going to cause pain no matter how you treat them. Even if you get an absolutely anatomical result, they're going to carry on having heel fat pad pain for a year. And that's the end of the talk, Raheel.
Thank you very much. That was a very informative talk, and I think all of us have learned quite a bit. I can totally vouch for that percutaneous technique, which I learned off you. There seems to be a bit of background noise there. It's, as you say rightly, it's reproducible, and it works almost all the time as long as you get your steps right. In summary, top 3 take-home points. Amer, do you want to just summarize before we ask the audience if they've got any questions? If you've got any questions, please feel free to use the chat box. We will answer your questions now. But I'll let Amer summarize with his top 3 take-home messages.
So what I'd say is that, first of all, it's a serious injury and it causes long-term morbidity and interferes with people's lives because it stops them from working. You need to be sure that it's an isolated injury, not part of a pattern of injury from axial loading, so you need to go through ATLS. And the third point is that the literature still isn't abundantly clear, and don't just take 1 or 2 papers and make your conclusions from those papers. I think you need to read quite widely in order to sort of appreciate the subtleties that can be drawn, especially from the systematic reviews.
I've got a question for you. We've got one from the audience, but I'm just going to finish off my question. So,
sure.
The percutaneous technique, when you have a lateral wall blowout, how do you actually get that reduced percutaneously? Do you just squeeze it together?
So, well, what tends to happen when you've got a short and wide calcaneus, when you lift up the articular fragment that's depressed, you also increase the length, and you get some degree of ligamentotaxis. By increasing the length, it makes the heel less wide as well. So you do get some improvement in the width of the heel. I've read about some ancient practices where for calcaneal fractures they were hit with a hammer, and I hope that doesn't happen anymore.
Okay, we've got a question from the audience. Would use of arthroscopy change your mind regarding amount of apparent cartilage damage? Okay, so what I think they're trying to say is, if you scope the joint and you find there's a lot of chondrolysis, would you proceed with fixation, or would you go for fusion? I suspect. Is that correct? Would that be something you would look at and counsel your patient accordingly pre-op?
Well, the problem with chondrolysis is that very often it occurs later on. It's not something that you can see immediately. When you look at the joint, all you can see is the split in the cartilage with your scope. So it's not really the right time to be making a decision, because it looks perfectly normal at the time. And because Chen has found that the rate of arthrodesis is so low, I'd be very tempted to give the patient the benefit. With an extended lateral approach, there are high risks involved. With the keyhole techniques, really the risks are a lot less significant for the patient, and you're not going to end up with you're not really burning any bridges. So you're going to be putting in percutaneous screws, which can be removed fairly easily as well. So it means that it might make your subtalar fusion a lot easier in the future if you ever need to do that. But I'm quite hopeful that the rates of subtalar fusion are going to be low anyway.
Amer, thank you very much for that talk. Just to round up for the audience, we're coming close to the end of our foot and ankle theme at OrthoNinja. Next week, we're going to be doing mobile flat feet, surgical management of flexible flat feet. Following that, we're going to be handing over the baton to the knee surgeons. The knee surgeons are going to be coming into OrthoNinja. They're going to be taking over and going to be talking about all things related to the knee. So watch that space. We're going to be sending out the links to the knee module coming up soon. But we hope to see you next week with flat feet. Amer, thank you very much.
Thanks, Raheel. Bye-bye.